This Week in Pediatric Oncology, the podcast exploring hot topics and exciting advances in childhood cancer. TWIPO is produced by Solving Kids Cancer, nonprofits located in New York and London dedicated to improving research and supporting families, because every kid deserves to grow up. Subscribe to TWIPO through your favorite podcast platform.
This Week in Pediatric Oncology, the podcast about new advances for childhood cancer. Hi, everybody. Welcome to episode 112, recorded on August 30th, 2023. I'm your host, Tim Cripe, from Nationwide Children's Hospital in Columbus, Ohio, affiliated with The Ohio State University. And I'm here with guest Luca Szalontay from Columbia University. Welcome, Luca.
Thank you so much for having me.
Just briefly, a little bit about your background. You got your MD at the University of Pécs in Hungary. You did a pediatric training at Georgetown University. I have some good friends there. You did your pediatric hematology oncology training at New York Presbyterian in Columbia, Morgan Stanley Children's Hospital, where you were also a chief fellow. And I guess you went, I don't know, a few blocks away, perhaps, to Memorial Sloan Kettering for your neuro-oncology subspecialty training. And now you're back to Columbia as an assistant professor in pediatrics and highly involved in the drug delivery innovation program. So we wanted to talk about that and talk about Focused Ultrasound, which we have already introduced to our audience in episode 103. If anyone wants to go back and hear Roger Packard talk about that, but we'll talk more about that as well. So welcome and thank you for being here to share some information about your program.
I'm looking forward to our discussion. I think it's a very exciting time for drug delivery, including focused ultrasound, and being at the forefront of this, it's been a privilege serving these patients. So I'm mostly looking forward to make sure that everyone understands what it means to put this kind of program together and to make sure that we can move forward with different collaborations. These diseases and serving these patients really takes a village. So we would not be able to do by our own. And I think that's one of the most important message of today's topic.
Yeah, it's a good point. Very complex diseases, and especially with respect to drug delivery, as are probably most of we're talking mainly about brain tumors now. In particular, I think about midline gliomas, and there's a blood-brain barrier that protects the brain from toxins that you might ingest. And certainly that also protects brain tumors sometimes from the drugs we administer. So let's just start there with the sort of the unmet need, the patients, the types of cancers you're mainly concerned about.
So our program is focusing on pediatric brain tumors and, as you mentioned, specifically midline gliomas. We started our work with DIPG patients, and then we included thalamic midline gliomas as well. Our program here at Columbia is the Initiative for Drug Delivery Innovation, and we are including different types of drug delivery methods to the brain. As you mentioned, we feel one of the reasons that our field hasn't been able to move forward with a pace we see, for example, with leukemias or other solid tumors, is because the drugs, we see them being effective during the in vitro studies or even during the animal studies. For some reason, they don't get into the brain as efficiently in as high concentration as we are hoping for. And one of the main reasons is the blood-brain barrier. As you mentioned, it's evolutionary very important to protect us from different toxins, harmful agents, but this is a shield which protects the tumor as well. All these chemotherapies which we've been trying to use in the past are not getting in the brain in the concentration where they would be effective. If we needed to use higher concentrations in order to get to the brain, then it would harm the patient. So that was also a limiting factor why we needed to overcome the blood-brain barrier and find other methods, direct or indirect, to be able to use and try to get better outcomes for these patients.
So what kinds of approaches are you taking to overcome that barrier?
So the two main methods we are using here at Columbia are the convection-enhanced delivery and focused ultrasound. And as you can imagine, these are the two spectrums maybe of drug delivery One of them, the convection enhanced delivery, being one of the most directive way to inject the chemotherapy or other therapeutic agents directly into the tumor through a catheter, and the focused ultrasound being non-invasive, using the ultrasound waves to open temporarily the blood-brain barrier so we can deliver the drugs, which we either give orally or intravenously, but you need to get it systemically instead of directly to the tumor.
Talk about those one at a time. So the convection enhanced delivery, tell us what that involves and how it works.
Yes. So the convection enhanced delivery is using a specific catheter you're placing directly into the brainstem. We're talking about DIPG patients. And what we use here is common baclofen pump. And that catheter is placed right in the middle of the tumor. And the tubing is thread under the skin, and it attached to the pump, which we place just subcutaneously in the abdomen. The reason we are using this pump, because what we know about the dynamics of the fluids, without applying a certain pressure, the drug would just be delivered based on diffusion. But having the pump and having the continuous pressure, that allows us to cover an area more like a globe. So it will evenly distribute in the brainstem, covering the majority of the DIPG.
So the medication is filled into the pump and then delivers it continuously. How long does that last?
Our study used the water-soluble penobinostat called MTX-110, and our delivery was about 48 hours long, which we repeated 2 times. So if you think about the patient came in on a Monday morning, had the surgery, we placed the catheter, and with an MRI, we made sure that the placement is appropriate. And in the pump, we mixed this MTX-110 drug together with a contrast agent. And this mixture was infused in a very slow manner into the brainstem. It was about, over these 48 hours, about 5 milliliter. This was done in ICU settings, and these patients were monitored very closely. And they had serial MRIs to see the contrast enhancement in the brainstem, trying to make sure that the placement is still correct and estimate the area which is covered with the drug. Then the patients had about a few days of break, and then we repeated the same treatment, another 48 hours, and then at the end of this, the catheter was removed with the pump, and the patient was able to go home in a few days after this treatment.
And each time they had to access the pump to refill it, so that was another surgery?
It was either under very light sedation or the patients were able to do it awake. It was almost like accessing a port, the central venous catheter for these patients. It was about a 5-minute procedure, just taking the remaining drug out and then refilling with a fresh one.
Okay, and the convection enhanced, it just refers to the pressure that the solution is under to sort of get it into the tumor and let it perfuse the tumor directly?
Yes, we didn't see much backflow. We tried to make sure that the placement of the catheter is away from previous biopsy. So we didn't have much problem with the drug distribution.
And tell us what the results were. How many patients did you do? And has this been published yet or presented somewhere?
It was presented on ISPNO last year in Hamburg, and we're currently preparing the manuscript. And we were able to enroll 10 patients total. Our age limit was from 3 years to 21 years of age. And the majority of patients were between 4 and 9 years. We had a couple of adolescents as well. We can say that the majority of the patients tolerated the treatment well. And even if it took some time for them to recover from the increased pressure in the brain during this treatment, but their neurological baseline was, with except of one patient, achieved by the first month following the treatment. We used different drug concentrations as well. So it was a feasibility and safety study, but our goal was to get to the recommended phase 2 dose for this drug, which we will be able to use in our subsequent studies. we can say that treating these 10 patients, we reached the highest concentrations we were planning to. And the patients, I would say we were able to increase the expected overall survival of the DIPG patients. We don't have the whole data set yet because we still have some survivors. So we're closely following them. And because it was a study we offered to newly diagnosed DIPG patients, obviously we had no control of subsequent studies or treatments they were enrolled in. So it's hard to get an unbiased picture, but I feel like that it at least gave these patients a fighting chance for participating in further studies.
Sure. And it sounds like it was mainly a feasibility safety study to be able to tee up further studies. So what are the next plans for a subsequent study?
As I mentioned, we are working with a large team here at Columbia, including a physician who's an expert in precision medicine. And she's using algorithm, which is able to identify something called master regulators in the cancer cells based on RNA-seq. And with that, she's able to predict what kind of drugs these cells would be sensitive for. We also noticed during these studies that DIPG is not a homogeneous type of cancer. Dr. Pavicic, who's leading this work, was able to identify 6 different subtypes of cells within DIPG, having different sensitivities to drugs. So our next step is to try to find the best combination of drugs with MTX-110, and that is what we're planning to move forward with in our subsequent CD study.
So the study then would be an individualized, personalized version where there would be different drugs in different patients depending on their mutations?
It seems like based on the computational data, each patient maybe not in the same percentage, but has the same subtype of cells, which show the similar sensitivity to these drugs. So right now, we don't have the capability to go to each patient and individualize their care. I'm really hoping that it's in the near future for us. But right now, we are just testing different drug combinations based on what we found with these subtype of cells.
Yeah. And one last question about convection enhanced. So you said you had mixed it with a contrast agent. So are you able to tell whether the perfusion is sort of throughout the entire tumor, or do you end up having a higher concentration by the catheter or different areas that don't get perfused? What were some of the findings there?
What we were able to see, and based on the theory that the drug travels together with the contrast, that we did the MRI after completing the infusion within 6 hours, and some of the patients had full coverage of the brainstem. Depending also on the tumor anatomy, some patients only had partial coverage of the contrast. This might not tell us exactly where the drug ended up being, but we're hoping at least it gives us an idea if the medication was able to get all the areas of the tumor.
Was there some contrast also in normal brainstem, or was it limited to the tumor?
It was limited to the tumor. Our neurosurgeon, Dr. Feldstein, was able to place these catheters right in the middle of the tumor. So if you imagine that the brainstem being closer to like a shape of a globe, then the idea was that with the catheter being in the middle, it was evenly distributed in the tumor.
Yeah, well, that's great. That sounds like a lot of progress and has a lot of potential for the future. So what about I guess in the last 10 minutes or so that we have left, the focused ultrasound? Tell us about that, the technology. Again, we talked about it a little bit before on one of the prior episodes, but tell us about what you're doing there and with it.
Our focused ultrasound machine is developed by our own Dr. Elisa Konofagu, who's a biomedical engineer here at Columbia. And it's a little bit different from the machine Dr. Packer mentioned, the InsightTech machine. What is unique about this device is that it's using neuronavigation, the similar device used by neurosurgeons in the OR. And also, this is only about a 5-minute procedure. So for that, our patient doesn't require sedation. We don't need an MRI right during the treatment to make sure that the drug delivery is appropriate. Because of that, we are able to use the focused ultrasound treatment more frequently. So we started our DIPG patients when they progressed the disease. So this study was open for progressive DIPG. And the first drug we used was oral panobinostat, with the idea that we can improve the penetration into the tumor by opening the blood-brain barrier. Our device is only able to open a few millimeters of the area at a time. So that's also different from the other device. That was during the time when panobinostat was still available in the US. Since it was removed from the market, we needed to find another drug. And that's where our precision medicine and computational biology came into place again and saving us, because it was shown that topoisomerase inhibitor, including etoposide, was one of the top drugs which came back when they looked at the drug sensitivity of the IPG. Dr. Fred Wu, who's my co-leader in this drug delivery initiative, and he's the one who's doing all the focused ultrasound studies in the lab, he was able to quickly use etoposide and change gears and show that etoposide entered the blood-brain barrier or went through the blood-brain barrier. And after the animal studies were very promising, we were able to revise our protocol and open the second focused ultrasound study with oral etoposide.
Are you also using, I think Dr. Packard talked about activating a drug, a pre-drug into are you doing that sort of thing too? Or is it just a matter of getting the known drugs into the tumor better?
It's getting the drug into the tumor. Etoposide is the commonly used drug, so it's already active. The way we set up the study is that we are giving the ultrasound treatment and immediately after that give the oral etoposide. Our patients get oral etoposide every day for 21 days. And the way the ultrasound treatment is set up is also a little bit more individualized because we are monitoring for the blood-brain barrier closure times. We noticed in our previous study that not every patient has the same closure time after the blood-brain barrier is opened. So to make sure that our study is safe and we're also maximizing the effect of the ultrasound, we are doing serial MRIs for these patients looking at the closure. The way we set our study up, that our patients undergo the ultrasound treatment and then receive contrast brain MRI, and we deem to have a positive result if we see new contrast enhancement in the way of the ultrasound. And what we learned that the majority of the patients have their closure within 48 hours, but some patients have actually longer ones, up to 70 to even 96 hours. So if we see the blood-brain barrier closure within 48 hours, then that's what our closure time. And we set up the ultrasound every other day. Usually we are on a Monday, Wednesday, Friday schedule. If we don't see the closure, then we continue to repeat the MRIs every 2 days. And for example, if the closure time is 72 hours, then we have a Monday, Thursday schedule. Or if it's longer than that, then we commit to a weekly schedule.
That's fascinating. So if a person has a longer closure time, and I didn't realize there was such a thing, then it's longer every time you do the ultrasound. So you can rely on it. Like this person's a 72-hour closure time and this person's a 48-hour closure time. Do you have any idea what determines that?
We don't know yet. We are running right now in animal studies the experiments because we were able to reproduce it in the animals as well. The jury is still out there. What's the biology behind it?
And if I understand it, so you're not mapping the ultrasound waves to the tumor itself, right? So there must be some normal brain in the path of the ultrasound. And does that contrast also get enhanced in the normal brain? Is that blood-brain barrier broken for the normal brain tissue?
So you are able to focus the ultrasound to the area of the tumor. So the ultrasound, the waves go through normal brain as well, but they focus on an area within the tumor. And that's where we're seeing the contrast enhancement, not in the normal brain tissue.
I see. Okay. So it's not necessarily mapping to the contours of the tumor, but it's within the tumor.
Yes.
Sort of affected.
Just like the neurosurgeons are able to pinpoint exactly where they want to do, for example, a biopsy based on the neuronavigation system.
Yeah. Okay. Interesting. And so this is a study that's ongoing and open now?
It's currently open, yes. So we are still accruing patients. What we changed in the eligibility criteria, because there was a huge need for DMG patients in the adolescent and young adult age. So now our age criteria is up to 39 years instead of just the 18 or 21, which is usual for pediatric patients.
And how long do you think the study will be open for?
We had our first patient during the summer, and we are hoping to enroll about 10 patients. So maybe another year and a half, depending on how many patients we are able to find, and also depending on the safety of the study. If we have any adverse events, obviously we need to reassess, but I'm hoping that we can complete all 10 patients. We allow the treatments until disease progression, and the total of cycles we are planning to give is 4 cycles, meaning that 21 days of etoposide and then 1 week break. And we give 2 weeks of ultrasound treatment during these 1 month period. Obviously, if a patient progresses early, then we can only do a few sessions. If we are able to do all 4 months, then it's going to be more successful and we can collect more data.
Great. And do you have information on your website about this? Or I'm sure people can go to clinicaltrials.gov to find out more about it. Actually, I just did that, typed your name in, and these studies popped up. So hopefully it's pretty easy for people to find. Would they also go to your hospital's website?
Yes, it should be on our hospital website as well.
Okay, great.
I'm hoping that we can serve the community. As you know, the DIPG parent advocacy groups are very strong, and they all know about our studies. And there's a DIPG navigator as well who's helping these families, and they all know about our studies. We are also part of the DIPG National Tumor Board. So on those case presentations, we can pre-screen patients and see if they would be a good candidate. The only eligibility criteria which we're often run into trouble with is any previous bleeding or any hemorrhage within the tumor. We're trying to make sure that, and we still don't have enough human data to know if ultrasound can cause any bleeding. So far, we didn't have any, but that's the thing which we're most careful about.
Yeah, that makes sense. Certainly with these kinds of new technologies, one has to be cautious about potential side effects, but it sounds like you've been successful so far, and it sounds like a nice advance and to be studied further, and appreciate your team being innovative. We're pretty much out of time, but are there other comments you'd like to make about either study or your innovative drug delivery program in general?
The other aspect I would like to just briefly mention is the liquid biopsy part of our program. If you think about focused ultrasound, we mostly focus on what goes into the brain, but we're very excited about what comes out. So attached to this study, we are checking cell-free DNA in collaboration with Memorial Sloan Kettering to see if we can learn more about the tumor now that we have this open blood-brain barrier, what the tumor releases and what we can identify in the blood.
And are you also looking at the spinal fluid or just the blood?
If we have an option or we have an Ommaya reservoir placed in these patients, we take advantage of that, but we would not do any spinal taps on these patients just for the sake of analyzing the CSF.
Great. Well, we all know that cancer in general, but certainly midline gliomas, there have been so many studies, so many potential innovations over the years, and we all know that there's still a large unmet need. So it's exciting to hear there are new ideas in the field and other things being tried. So thank you for sharing all those with us today on our program.
Thank you so much for having me.
Yeah. So, and also thanks to the team at Solving Kids Cancer, a nonprofit charity dedicated to improving survival through creating novel treatment options for children. Remember, the more we learn, communicate, share ideas, and work together, the faster we'll reach the day when all childhood cancer is preventable or curable. As always, keep up the fight. And thanks for listening to This Week in Pediatric Oncology.
We welcome your comments, questions, or thoughts on topics for future episodes. Just drop us a note at twippo@solvingkidscancer.org. You can follow Dr. Cripe on Twitter at KidsOncDoc, send an email to Dr. Weigel at weige007@umn.edu, and find all TWIPO episodes at solvingkidscancer.org.